Welcome all. The participant number is climbing. I'm going to wait for that to stabilize and then we'll get started. All righty, it appears we're holding at 98 participants. I want to welcome you all to this special webinar. We have a great attendance today. We have Dr. Mark Levine, who's agreed to give a presentation and then a Q&A to follow. As an introduction, appointed by Governor Phil Scott, Dr. Mark Levine began serving as Commissioner of Health in 2017. Prior to this, he was a professor of medicine at the University of Vermont, an associate dean for graduate medical education, and designated institutional officer at the College of Medicine and the UVM Medical Center. He obtained his BA in biology from the University of Connecticut and his MD from the University of Rochester. He completed an internal medicine residency at UVM and a fellowship in general internal medicine at University of North Carolina. Dr. Levine has a reputation as an outstanding teacher and educational innovator, receiving teaching awards from the medical school and the Department of Medicine. He maintains his faculty appointment and continues to teach. Prior to becoming commissioner, he practiced general internal medicine with special interest in solving complex diagnostic dilemmas, health promotion, disease prevention, screening, and clinical nutrition. I hope you can all welcome Dr. Levine, who's going to start with a brief presentation.
Thanks very much, Rick. And I appreciate this incredible turnout today. We're going to do a little bit of past, present, and future with regard to the pandemic, and try to also maintain a little bit of a focus on keeping healthcare organizations and patients safe. Show how we've tried to do that already, how we anticipate doing that in the future. Like anything with COVID, you never know what to expect. And there's always the opportunity for it to throw us a wrench and to do new and interesting things. I always like to say that one of the adages we have in medicine is to be a lifelong learner. And we've compressed that into 14, 15 months of lifelong learning, almost every day learning something new, I have to say. Let me advance my slide. So what we'll do in the next short period of time is really talk about the pandemic a little bit and how we've shaped policy based on the epidemiology, where we've come from and evolved to. Talk a little bit about medical vulnerability and talk about what the future holds in store. So let's go back a year and several months. Everything happened very quickly. We had our first case, we had our second case, we had our first death, and all of that happened within 10 to 14 day period. We had that wonderful curve that everybody remembers that we called the flattening the curve, showing that if we let the curve go out of control, cases would just skyrocket up and the entire healthcare system would be overwhelmed and people would have consequences, hospitalizations, deaths, etc. So the whole focus was on how do we flatten the curve. And we ended up sequentially shutting down things in a very rapid phased manner to the point where literally within a few weeks, we were in stay home, stay safe, which are now, I guess, called lockdown conditions, though I hate to use that term. We really had to do that. Those are really mitigation strategies because we were unable to do the primary viral epidemic strategy, which is containment. All along, all the settings that people on this call represent were really top of our list for what needed to be protected. Anything where healthcare was delivered, anything where people lived in a congregate manner. So protecting the most vulnerable, though it is one of Governor Scott's 3 themes that he was elected on and continues to have every term that he serves, this became really visible as we started to manage a pandemic. Just to give you that recap on what the heck is containment, it's everything we've been doing for many, many, many months now that we actually can test people. In the beginning, during that lockdown phase, there was really no testing available. And then when the CDC finally had a test, it took a while for that to get utilized because it had some imperfections. And there was no ability to scale it up to a reasonable level. It was kind of like whole genome sequencing was a couple months ago, where who knows if we had the B117 in this country because we could hardly sequence enough samples to figure it out. Now we can do sequencing on anybody. Well, same thing happened with testing. So the core of containment is you test widely. You take the people who test positive and isolate them because they become cases. You interview all of them to learn a little bit about where they may have acquired the virus, but just as importantly, who they may have been with during an infectious period. And that's called, of course, contact tracing. And then the people that have come out of that contact tracing who are at high risk of acquiring the virus and spreading it to others, you quarantine. Pretty simple process, but we couldn't do it initially. And that's why we did all these so-called non-pharmaceutical interventions or mitigation strategies. But we started to rapidly then evolve into containment. We knew a lot about respiratory viruses and what we'll call contact science, meaning the sort of three phases of contact that are most important. One is close contact, one-to-one, like you might have in your doctor's office, like you might have at the bedside in a hospital or nursing home, like you might have if you're getting your hair cut. Then we talked about contact density, which is essentially avoiding crowding because the virus spreads very quickly and people are in close quarters. And then also talked about contact intensity, or how long you're in contact. And indeed, these things became principles that went into what contact tracing became all about. And when we started to talk about how many minutes you needed to be with people and what distance you needed to not be with people, that's what contact tracing was all about and how to prevent yourself from becoming a case or a contact. We also talked a little bit about ventilation, but that became much more sophisticated as time went on. I think mostly what we learned is that people hadn't paid a lot of attention to ventilation and needed to in a renewed way because of this virus. We still have lots of questions that arise about ventilation, and we still have a sense that many buildings were inadequate and have now been brought up to speed in terms of airflow, in terms of air circulation and recirculation. And then we validated simplified guidance, which is basically stay home if you're ill, wash your hands, practice respiratory etiquette by coughing into your elbow, etc. And then, of course, the rhyme, masks on faces, 6-foot spaces, uncrowded places. Because really, it could be as simple as all of that. If people comply with that, understand it, and learn a new way of living their lives prior to the advent of vaccine. Getting into the healthcare sector, we really had to focus on keeping everyone safe. That meant whether you're coming into a hospital, an outpatient practice, or a nursing home, or for that matter, a correctional facility, or even college campus, you needed to really start thinking about patient visitation policies, because many of those places might have had policies that would have protected everybody while there, but the disease gets introduced by the visitor. So the visitor becomes a crucial element. Next, when you're coming into a healthcare setting, whether it's inpatient or outpatient, and you're going to be getting a procedure done, what have you, what kind of testing protocol and quarantine strategy? You might all recall that we ended up having testing done within a certain number of hours of a visit, never mind a procedure. And then until you got that result, you were quarantined. And until you had that visit, you were quarantined so that you wouldn't go out and then acquire the virus in between in anticipation of that visit. And then finally, all the things that happen as you hit the door, filling out a symptom checklist, having somebody take a temperature, doing a education about all of the symptoms, masking, and then, of course, the fact that so much of our healthcare was done by telehealth. And then the Agency of Human Services, we had produced guidances for various procedures on the inpatient and outpatient side. A lot of this was very protective and very important. Keep in mind, it was occurring at a time where the majority of the public were petrified about going into a healthcare facility and wanted to keep as far away from it as possible. And only in dire need would they dare go. We've learned, obviously, over time that that fear was misplaced and that indeed some of the safest places we had in Vermont were healthcare facilities. I mentioned some of the kinds of guidance that have occurred both in the past and present with symptom screening, with vaccination status screening. There's a little controversy about taking or not taking temperatures. Most of our data showed that fever was a presenting symptom only about 30 to 35% of the time. So if that was going to be your strategy for screening, you're going to miss a lot of people and be misled. Obviously, masking became very non-controversial in that setting. And then we evolved as time went on into this pre-procedure testing for asymptomatic patients and used terms like may require, consider utilizing, if you're going to have a procedure that involves instrumentation of the airway. So we're able to get much more specific about that. Again, giving a lot of flexibility to the healthcare setting and getting as strict as they wanted to be, but also allowing them to be a little less strict if they wanted to be for procedures that clearly had lower risk associated because they didn't involve the airway at all. We also had these issues of getting the procedure testing done for the inpatient setting within 7 days, forcing people to be socially isolated ahead of that time. A lot of things that nowadays we can have modified our stance on. Obviously, PPE early on in the pandemic was, I could call it a disaster, not through any fault of ours, but through a national disaster effort. Now PPE, you can't find people to give it away to, but the reality is we're going to need it for the next time. So we need to continue to stockpile for sure and realize that there are times that different levels of PPE are appropriate for different levels of contact, different levels of care, if you will, low versus medium versus high risk care. We also had a lot of policies in place about waiting rooms, and the reality is the waiting room became the car. Sometimes it even became the car for the person who was the patient. They weren't even allowed in before the visit until they got the phone call. Other times they were allowed to come in and sit in the waiting room, but nobody else could. They had to wait in the car. March 30th, which is the last guidance we put out. Obviously, we were in the era of vaccination at that time. We had a lot of issues regarding opening visitations in multiple settings, whether it be nursing homes, whether it be hospitals, et cetera. So we provided a lot more laxity, if you will, in the approach to allow people to be visitors if they were fully vaccinated. Questions arise there, of course, as to do you need proof? What kind of proof would that be? Is there a passport? Is there a card? Is it a basically verification by the person saying, I am vaccinated and you accept that? Self-attestation kind of thing. Then we had different rules for not fully vaccinated, but even there became a bit more, I would say, compassion-laden allowing for the fact that it's kind of important for an individual visitor in labor and delivery, for somebody in a pediatric setting, clearly in the end of life setting, often in an anxious person who is needing somebody to accompany them to a procedure. And then, of course, just in areas where the person is unable themselves to communicate their needs well and somebody needs to advocate for them. We had similar guidance for the inpatient and outpatient settings. And then we had issues regarding what about these visitors? Are they vaccinated? Aren't they not vaccinated? Make sure they're masking, make sure that we know where they are. If they're supposed to go from point A to point B, trying not to allow them to go via point C or point D where they don't belong and potentially could cause problems and require a lot more contact tracing. And that brings us to where we are now, which is literally in a day or two away, maybe 3 or 4, till we get through the next 3,000 Vermonters who step up and get vaccinated and bring us to the 80%. That could happen, any time between now and the end of the weekend, I would think. Don't hold me to that, but I just really can't imagine it going longer than that. If you'd like to set up an NCAA type betting pool for the Final Four, to be my guest. So what is next? Well, what is next is that we are going to rescind guidance. There will be nothing that we are requiring. We're still having a little bit of an internal debate about should we just refer everyone in healthcare to CDC guidance? Not that they have to follow it, but at least it provides them with the menu of options. Or should we just say contact with AHS or VDH? Because to be frank, not that we've ignored CDC guidance, but we've kind of been on our own path all along. And we've integrated CDC guidance, but there are times we haven't used it all. And we've taken a little bit of a pick and choose approach. And that's really in an informed way, because if you think about it, CDC is really the whole country. Well, Vermont's got an 80% vaccination rate for the eligible population. Mississippi is less than half of that. Maybe we shouldn't be playing by the same rules Mississippi plays by because they have a very different situation there. So maybe we should be looking at, our percent positivity rates, our level of transmission rates, numbers of cases, et cetera, and say, we can do this safely in Vermont, but they couldn't do this in Mississippi. So that's why we'll sort of finalize that in the next day or two, but that's the way we're thinking. Obviously, there are times that we don't have a choice because there are regulatory stipulations. And so we can't tell a skilled nursing facility, don't worry about X, Y, or Z, when the reality is if they don't worry about X, Y, or Z, they lose accreditation, or the regulators come down and go, we're not paying you for those services because you weren't paying attention to the rules as we've written them. So again, we have to be cognizant of that. Let's get to the present in a little more broad way about just the vaccine and what it means for our future. And this will be sort of the final part of my presentation. We have to trust the vaccine. The 3 truths that the CDC provided when they sort of surprised the whole world and said, hey, you can unmask if you're vaccinated. The 3 truths were, number 1, we have clinical trials showing how efficacious these vaccines are. But now we also have a number of real world studies showing that they're also what we would term the word effective in the real world. So when applied outside of a study population setting, and in a very high risk setting like healthcare workers and frontline workers, they still have the same efficacy rates and the same safety profile. So we need to realize that they're working in the real world. Second, and it's another part of working in the real world, even with these variant strains, which often are called scariant strains because they're freaking people out, the reality is most of those are not evading the vaccine. And the ones we've seen in Vermont, which, B117, B146, B142, most recently we found P1. These are all susceptible to the vaccine. The South African we found one time, and that one for the vaccines that are approved in the US also does pretty well. And then most recently, the so-called Delta variant from India, we have found on one international traveler in Chittenden County. But again, if you look at our statistics, we're having less cases every day in Vermont, and nothing else is changing. People are not dying, people are not getting hospitalized. So again, these variants don't seem to be getting transmitted widely through our community and causing trouble. And having a high vaccination rate is still protective. And then the third vaccine truth is that you're less likely to spread the virus if you're vaccinated. Now, that's the one that has the least strong evidence. It has good evidence. A lot of the vaccine trials, people were still swabbing their noses and seeing if you could culture virus, et cetera. But the reality is, it's not like 100% less likely to spread virus. Sometimes it's 60% less likely, sometimes it's 70% less likely. But I put the word viable in that line because even when you get a positive PCR in someone who was vaccinated, most people are questioning if that virus is actually viable or able to infect someone else, even though you can detect it because the tests are so sensitive. So keep that in mind. Bottom line, vaccination equals protection. Another bottom line is there's always going to be somebody who's unvaccinated, either because they chose not to be, or because they were unable to be vaccinated, or because they are a vulnerable person with immunosuppressive drugs or immunocompromising conditions. Fortunately, some of these will have actually had COVID, so they'll have that natural form of immunity, but there'll be many that actually are still susceptible to the virus and need to be protected. They need to do most of the protecting by living their life appropriately, being cautious and wearing masks. But there may be settings where we need to also mask up, even if we're vaccinated, just to provide that extra ounce of prevention for someone who we know is susceptible and indoors with us in a more crowded setting. Lastly, and I'm really serious about this one, and maybe during the Q&A you can help me if you've had successes or failures, we must raise the vaccine acceptance rates in staff of long-term care facilities. That is some of the population that has the lowest rate of acceptance of the vaccine. And fortunately, the residents of those facilities are very highly vaccinated, but it's just a shame that we can't get this rate up. Some of it, I understand, has to do with the population that's being hired. They're very ethnically diverse. There are health equity issues. There are disparity issues. There are historical injustice issues. But we seem to have overcome that across the state in many other venues. And just frustrating, we can't get through it in the long-term care facilities. On April 26th, this was the infection control recommendation from the CDC for healthcare facilities. I'll just read it. In general, healthcare facilities should continue to follow the infection and control recommendations for unvaccinated individuals, which means quarantine, testing, things of that sort, when caring for fully vaccinated individuals who have an immunocompromising condition. So again, just to reemphasize, that's a special population. Sometimes we know they're amongst us because they tell us. Other times we really don't. So we have to be very careful, and they have to be very careful. As I've been publicly saying, we hope before the end of the year, there will actually be a validated, not only qualitative, but quantitative test so that somebody who's been vaccinated but has one of these conditions would have a much better idea of how protected they may or may not be. Right now, FDA has said we don't have that test fully authorized yet, so don't just start testing people with any serology test. We prefer you don't test them at all because you'll end up giving them a false sense of security or more likely a false sense of anxiety. So leave it at that. And then finally, the future. What are the variables at play? Well, the degree of vaccination in Vermont won't be much of a variable because we're going to be 80% of people 12 and older, and that number is only going to grow. So it'll be higher than 80% because we're not stopping at this point. The only thing 80% means is Vermont Forward has come to its end and there's no more regulations from the state level. But we'll still have clinics, you'll still have clinics, and the pharmacies will still have clinics, so it's not going to go away. The region is also a nice feature because it's the best part of the United States right now with regard to vaccine uptake. And even if they lag behind Vermont, it's not by more than a few percentage points. So we'll still be number one, but everybody who's in the top 10 will be surrounding us. So there'll be good community immunity, if you will. Notice I'm not listing a number that is required for that kind of herd immunity. But boy, if we can't have it at 80+%, then I don't know what we could have it at. So we should be pretty darn close by there. And that leads into the degree of viral suppression, because if you really get that much vaccination, there can't be many people the virus can keep getting transmitted to. So it will keep reaching dead ends. And indeed, even if you've chosen for some philosophical reason to be anti-vaccination, a lot of that population will be protected if the state just doesn't have much virus around. Now, they won't be protected for a lifetime in a big way because they are still going to have the same susceptibility they've always had. And you put them in a Mississippi situation, they're going to get infected and have to deal with whatever outcome that occurs from that. We're going to still follow all of the usual data, case counts, hospitalization, deaths, positivity rates, because that tells us how much is around. We just won't report it as often. So already we've gone into a sort of Sunday night through Thursday reporting, and we'll continue that for a bit. And then if we need to have mitigation measures to suit the conditions, we'll implement them. But right now, we're not giving up on contact tracing and containment by any means. And testing is still available. Testing will evolve into a still regional availability kind of thing, but there'll probably be like 14 centers for COVID that will have testing capability, have vaccination capability, et cetera, as well as our healthcare partners, obviously. Then I think this is my last slide. What are the unknowns in terms of the future? A lot of people think this might become a seasonal respiratory virus, and that's why it's gone away now. I'm not so sold on that. And in fact, now some people are buying into my thinking because, you know, if you remember last summer, Arizona blew up, Texas blew up. Parts of the really hot US in the summertime had a surge. People are starting to predict that again for lower vaccination rate places in our South again. So is it because people are so hot that they're only going indoors to air-conditioned settings and all congregating, or what? I don't know, but clearly the virus doesn't go away in that season. And if it happens twice, I mean, you can't be fooled by that. It's 2 years in a row. So I think we need to be cautious year-round and think of this as a non-seasonal virus for the time being. And maybe it will be worse during the time of year we're indoors in the winter, but it won't be absent the other times of year. As opposed to like influenza. When's the last time we saw influenza being a big deal between May and October? You know, it's pretty unusual cases that would occur during that time. Will we need boosters? Everyone thinks yes, nobody has a date, and that's because we haven't, well, we may have just reached the 1 year point for the people who enrolled in the clinical trials of vaccine, way back in the beginning. So we need to analyze the data coming out after a year of vaccination. I think the agreement right now is it won't be as soon as 6 months after vaccination. It could be as soon as a year, but it may be longer than a year. We just don't know. Part of that has to do with the variant strain discussion, because if the variant strains actually become much more prominent and they become much more transmissible and cause much more serious illness, and somehow, because of this mutation, evade some aspect of the vaccine, then we're in a little more trouble. And then we would want to get boosters out quickly. There will probably be the mRNA formulation, because that one can be tweaked very quickly with a new strand of mRNA that matches the concerning strain that you have. The other question about boosters is, do you get boosted with the drug you originally got? Let's say the variant strains aren't a big deal and you just need the same vaccine. Is it better to get J&J after you've had Pfizer the first time, or vice versa, or what? And so those trials are going on as we speak as well. So those are unknowns, but the good news is we have lots of good research going on that I think in a timely way, at pandemic pace, if you will inform us about these decisions that will have to be made in the fall and winter. I make a big deal about this national and regional immunization rates because, viruses don't know any borders. For the longest time, literally until December, a few months ago, Vermont was truly an island in the middle of the United States. And it's really hard to be an island unless you're Hawaii in the United States. Yet we were managing to do that. But when the Northeast had its big surge, we were kind of like stuck. There was no way we could escape that. And that's because of travel and all of that. So I look at regional and national rates very closely, because if things are going to happen with the variant strain, if things are going to happen with the virus overwhelming healthcare, et cetera, we're going to start seeing that in lower vaccinated parts of our country. And don't be fooled into thinking that won't have any impact on the Northeast, because of the nature of travel, it will. And then, of course, I'm really, I'll use the word scared about the global issues, because the fact of the matter is, it's a very small percentage of the rest of the world that has received vaccine right now, and especially of the undeveloped global world. And that is where you get the Indias occurring. Not that India is undeveloped, though certainly parts of it are, but the fact is, whether you have a large population at risk and you have a strain that begins to take over that's very transmissible, it's going to overrun that part of the world, and it's going to show up in your part of the world. And the whole concept of virus mutation depends on its ability to be transmitted between people. If it keeps hitting dead ends, it's done. Nothing happens. But if it keeps going from person to person to person, every time it does that, it has the opportunity to, again, mutate, cause a new strain, and hopefully, if it's smart, it will be a smarter and wiser strain that knows how to infect even more people, and that's why it can take over, and potentially can make more people very sick. So there's a lot for us. I won't use the word to be worried about, but to really keep our eye on the ball with regard to the whole world. And then the last two things I wanted to mention have nothing to do with the vaccine. They have to do with healthcare. First one is a lot of comfort with telehealth on the part of healthcare providers and patients. We shouldn't throw it away. Yet we do need to have more in-person medical care, obviously, as well. And there's some things you can't do in telehealth. But I do think as a healthcare system, we need to learn that not all visits need to be in person. A lot of healthcare can be done very efficiently through telehealth. And the payment for telehealth should remain in play, if you will, and not force people to have to be in person to get reimbursed, et cetera. Which leads me to the second thing, because we want people to return to paying attention to their health care. And there's a lot of fear that is now being supported by literature that says that, number one, screenings have not occurred, and there have been long periods of gap. That has to do with cancer screening primarily, but a little bit in cardiovascular screening as well, and in immunizations in kids. And there's great data to document all of that. But there's also this documentation of the, not the inability, but the lack of comfort people had presenting to emergency room settings and urgent care settings when the pandemic was really raging, and how many emergency producing symptoms didn't lead to an emergency visit. And the person lived, but they may be living with sequela of something that they maybe could have taken care of. Or they had their warning signs and they haven't really picked up on them yet and got them taken care of. So this issue of sort of returning to a state of health in the country, we've got to start facing again. We also have to start facing sort of that lifestyle behavior change issue. A lot of people did try to get healthier during the pandemic. They started bought home exercise equipment and what have you, and tried to do things. A lot of people did not, though. A lot of people ate more, and people are talking about the pandemic 10, the pandemic 20, whatever number of pounds that they may have gained because they were sitting at home more, unable to do as much. And then there's just the idea of people who had a predilection to engaging in bad habits, and because of stress and anxiety of a pandemic, fed fuel to the fire and picked up on smoking, kept vaping, started to use substances of abuse, etc. So we're going to have to see the fallout of all this in our country and see how we can rectify it. But that should be a priority as we get into this era of, at least now, being heavily vaccinated and being able to engage in health and healthcare again. So let me stop there and open things up, and I'll let Rick kind of take over again.
Thank you very much, Mark. So we're going to start the Q&A portion of the webinar. You'll all see the Q&A button on the bottom of your screen. If you click on that, you can type in any question you so desire. I would encourage you all to open it up. And if someone else asks a question that you are also interested in the answer of, you can hit the thumbs up. That will indicate an upvote, and we'll make sure we prioritize those questions. We may not get to all questions that are asked during the webinar, but if you type them, we can try and answer them after the webinar as well. So please do ask questions that you have for Dr. Levine. I do have a few that were submitted before the webinar started, and I'll start there while people are typing in their questions. The first question we have is, as an employer, how should I advise employees who are vaccinated but have loved ones at home that are not, such as those with children under 12? How can we best protect those at home from catching COVID?
Yeah, so I think we need to come to grips with the fact that if we're vaccinated, the likelihood of us transmitting virus to our children who can't be vaccinated is still low. We need to make sure they're in the right settings and not in the wrong settings. We need to make sure that they, who actually are much more comfortable with masking than many adults, continue to mask at the right times in the right places. And we need to watch where the virus is in Vermont. You know, because I could foresee our pediatric community believing that we should mask up, you know, in schools in the fall until the vaccine is available to those under 12. But then again, I can also see them saying, well, gee, we are a low transmission state. Right now, we are the only low transmission state, but let's hope we can stay that way. And we're so low transmission that maybe we should relax on this and not have to mask. But as an employer, I don't think you should be, worried about your employee having to do something special at work because they might interact with somebody at work who's unvaccinated and who has the virus, because again, you shouldn't be able to be transmitting the virus to your kids. And the unvaccinated person at work should be protecting themselves and others by doing all the right things in terms of masking and distancing.
Great. About masking. So I had one pre-submitted, and Melissa had sort of followed up on that. Currently, healthcare workers are required to wear masks at all times, regardless of vaccination status. Are there any plans to, in the future, or what time in the future, are we going to look at this where perhaps we don't need to, especially in the non-clinical spaces where healthcare workers may be?
Yeah, we're going to have to evolve to that point. I mean, everybody still wants these institutions to be the safest they can be. CDC, will probably be a little strict early on and then relax. I would probably take their signal, if you will, because again, when you're interacting with the public, it's just such a wild card. You're interacting with all kinds of people, with all kinds of vaccination status. And we also know that not 100% of healthcare workers are vaccinated. It's very high, thank goodness, but it's not 100%. So I think there's going to be a sort of time period to get comfortable with things where we're going to be more strict and then get more relaxed. It's the best I can answer that for now.
All right, another masking related question. So I'm going to pull up a infograph I have here. So this is a comparison of 2019-2020 influenza season week 6, and here's 2021 same week. Now, obviously, there's other reasons why this happened, but masking seemed to have a significant impact on influenza transmission across the state and invariably saved thousands of lives. Are there any thoughts around general guidelines or recommendations around masking during cold and flu season as a routine measure to prevent these kind of things from happening again?
Yeah, the $1 million question. I have to admire the tolerance our population has had for masking, the majority of the population. And everyone's sort of heard of this, data that there's just no flu around, period. I think the only reason we still have people getting testing in Vermont now for COVID is because many of them have allergy symptoms and common colds. And the fact that everybody could take their mask off, well, the common cold virus didn't go away. And now we're finding out it's actually been here. And the reason I trust our low % positivity rate is because we're finding the COVID, but we're also finding lots of people who were symptomatic with other things. So those things are still around. Fortunately, those things aren't the flu. They're mostly, rhinovirus and stuff like that. Even other coronaviruses that aren't this one. So the reality is masking has been very effective. I also think people are liking the freedom they have now if they're vaccinated and not masking so much, but they've been very accommodating, taking their mask into a store, and if the store insists on it, they can put it on and what have you. So the book isn't closed on this. I think what you're going to see, though, and what we're doing in Vermont as an example, is government not interfering so much anymore. We've been regulating, we've been enforcing, we've been using emergency orders to do things. This is going to have to be a cultural thing. And the reason it works in Southeast Asia, or all of Asia for that matter, is because culturally, everyone there has become used to that long before COVID. And it wasn't a heavy lift for them to wear a mask for COVID because they were already doing it. And they recognize the value of that. That's not so true of Western civilizations. And I think it's going to be a big leap for us to be able to do that. But I wouldn't expect it to be one of those state of emergency, everybody wear a mask thing. It may come out as a strong recommendation. So stay tuned.
Great. I'm going to ask a question that came up in the Q&A. Where are we in the research of safety of vaccination for children younger than age 12?
Yeah, we're very close. So all the companies, well, the two companies, Pfizer and Moderna, have basically said, we're going to have data in the fall. And I'm thinking late September through October kind of range. And then, of course, once they have their data and they put it all together, they go for the emergency use authorization, and that process takes a very short time, and then you've got vaccine to use. The reason they're confident is they already went through the phase 1 studies. And the phase 1 study is really the dose ranging. So trying to test out different doses, because obviously a 3-year-old shouldn't be getting the same dose as a 30-year-old, though it seems that a 12-year-old can be, but a 3-year-old probably not. So they've done some dose ranging studies so that they have an idea of where to start. And that's where they're doing their now phase 3 studies in these younger kids. So it's not going to be as long as we thought. A lot of people were thinking 2022 before we'd even begin to think about having an EUA. And now it's going to be later in 2021.
Great. Earlier in your presentation, you had talked about some of the behaviors, both good and bad, of Vermonters in the pandemic. And one thing that had been highlighted in a variety of articles is how alcohol sales and the incidence of alcohol use disorder has risen dramatically as a result of the pandemic. And also mental health disorders have been exacerbated during the pandemic. Are there any plans in place to help address these social concerns?
Yeah, so I don't want to confirm that alcohol use disorder has gone up. I do believe that alcohol use has gone up. And the sales were, as was stated in the question. And people have learned that the takeout sales kind of thing, the drive-by, all that is actually a good business model, and the governor encouraged that. And that's fine. I'm not so sure, because we do have an increase in opioid use disorder deaths from unintentional overdose. I'm not sure I have the data to support the alcohol, but let's assume it were true, because if for nothing else, it makes sense. It was a coping mechanism. People may have gotten worse in that habit. Our ADAP section, Alcohol Drug Abuse Programming, has not been asleep during the entire pandemic. They've been very actively involved still. So whether you're treatment for alcohol or treatment for opioids, all of those availabilities have been open. Residential facilities have been open for people to go to during the pandemic. So AA has occurred, even with sometimes being Zoom, sometimes being in person. And all of this is going on and on. So we are going to obviously have to reassess how big the problem is and make sure that we're aware of it if it's bigger than we ever imagined. But nothing that was available in the past has changed. It's all continuing, and it's getting a lot more attention. I don't know if I answered the whole aspect of your question, because there were a lot of sentences there, but.
Yep. Another question is around telehealth visits. And a lot of people are in agreement that the telehealth visits are good for our patients. How can the state assist basically with the payment of the service to ensure that it's paid appropriately?
Yeah, I mean, this really emanates from the federal level. So, I mean, from the very start, it has to be something that the government wants to continue, sees value in, and creates payment mechanisms for. So, Medicare and Medicaid sort of lead the charge all the time, and the payers, the other third-party payers, follow suit usually. So it has to be that kind of progression. I wouldn't expect the state to play the lead role, but having said that, we are so tied in with the government because of our, what do you call it, payment model, our all payer model. I'm trying to think of what the A was. The all payer model. We are continually working with CMMI, which is the Centers for Medicare and Medicaid Innovation. And everything we do and everything the Vermont, the Green Mountain Care Board does and all of that really comes from the same place. So the bottom line is we are going to continue to be working with them. And telehealth is something that is not off the drawing board by any means. It continues to be front and center. So I have high hopes for that.
And one more question around, potentials for future years. If this does follow a cyclic pattern, at least in Vermont, will there be available resources like the Outbreak and Prevention Response Team and other of the state resources to help in the efforts of facilities and organizations when they're having challenges with COVID?
Yeah, absolutely. So, we're trying to get back to work as a health department to do all the things we're supposed to be doing in addition to managing the pandemic. And the federal money that's coming in, thank goodness, is robust. So we're going to be able to do a lot more hiring and have a less lean and mean operation than we've traditionally had to have. So we will have a whole COVID unit, essentially. And that COVID unit will be dedicated to ongoing surveillance and management of the pandemic. We will continue to have contact tracing and containment. As I said earlier, we have an entire group set up already to do that, contracted with. Testing and vaccination through these regional centers will continue. We're not going to take our eye off this ball by any means. The only thing that's going to change for what people will notice in the very near future is the lack of the government telling everybody what to do all the time. We'll still advise people what to do. We'll provide good guidance for what to do, but we won't be telling you what you are required to do all the time, unless conditions change. And then, of course, we'll change with them. But that's sort of how I see the future going for now. And, Vermont has stepped up to the plate. It's really kept us very safe by having such a high vaccination rate. So I'm going to do my best to keep Vermont and New England as an island, if you will. So no matter what the conditions become around us, we continue to try to be as protected as possible and continue to try to live the way we hope we can be living the rest of this year into the future. So I want to end on that optimistic note.
Great. Mark, thank you so much for your time. This was really valuable. Thank you to all 112 people who joined in this webinar. I hope you got some good information. If there are questions that you had that you didn't get answered and didn't submit them, please email myself or Andrea. I think you all have our emails and we can try and get those answered for you.
Thanks for the invitation and goodbye, everyone.
Have a good afternoon.